Mike and I were doing. I think we advertised for over a year.
Wow.
Well, blessings upon you.
What's that?
Blessings upon
Blessings
Yeah.
upon you.
It's been a really good change for my family.
Good.
Like when you're an outpatient doc or provider, and you've been around for a decade with a group of patients, like on your days off, there's all this work that's just constantly coming in. And like you can try not to touch it, but you have to. I mean, you go back to work, you just have a day of work waiting for you. So with the hospital, even though it's more intense work for a week. Like when I'm off, I'm off. I close my computer, I'm done.
That's really good.
So, and it is, I've never experienced that as a physician because at residency I came straight down here and started doing what Mike and Lori had been doing all the time. So I don't know how long this will be. It's nice. I like it. I miss my patients, but at the same time, I think it's going to fit at least my family life until the kid. I mean, who knows? I probably have like 5 more years when my kids want to hang out with me. I don't know.
Well, you see your patients all the time anyway.
Yeah. Mm-hmm. It's nice being in a small town too. And I still get to see everybody. And I still, I mean, if the clinic needs help and I'm not busy in the hospital, I go over and help. But it's pretty rare. The hospital's been busy. Well, today I'll jump right in, and sorry, go ahead, sorry. Yeah, no, go ahead.
Hi everybody!
Hello.
My name is Sophia and I will be making announcements today. I work here at the library. First of all, I'd like to thank everyone for coming and enjoying this program. But before then, I'll make announcements for the upcoming week and their programs. This Thursday at like 2 p.m. we have a talk with our author Randy Samuelson Brown on the Western horse and their importance to settling the West. That'll be at 2 p.m. And on Friday the 24th at 2 p.m. we have Unearthing the Past by Eden Walker, and it's talking about the history of the Rio Cuchero Valley and how they were able to find it and all the analysis through archaeological finds. Refreshments will be provided. Now, without further ado, I'd like to hand this off to Dr. Dutton.
Thank you. Thanks everybody for coming. This is really cool. I enjoy these a lot. So format might be a little different today. That I'm just kind of in a hurry, and I apologize. I double scheduled myself. I was supposed to be in med staff meeting, which is quarterly, and I don't know that maybe I do this quarterly-ish. It's probably not. So it's just really bad scheduling on my part. But my med staff meeting's going on right now, so I was doing that. I'll do this, and I told him it'll be about an hour. I think normally I say, hey, interrupt me, stop me, we'll talk about that topic, and this can take as long as it needs to. But I would say probably let me go through the presentation. If you can, try to remember questions, and then we leave questions at the end and see what we have time for. Kind of go from there. This topic is one of my favorites, oddly enough, and I don't. I wish I hadn't done this to myself, but just a little background on why it's important to me. So my path of becoming a doctor, having worked in medicine and kind of seeing other providers and doctors work in an outpatient family practice, which was here, is what got me interested in family medicine in the first place. But you got to imagine, like the 27-year-old me going through medical school and residency, like had no idea what was going to transpire, and like all the information that's come my way, and like medicine is not anything like what I thought it was when I started. But the one refreshing thing that keeps coming back is like having chosen to be a family doc, I still feel like I'm doing like one of the most important jobs, because when you look at the money of medicine and where, at least in the United States, where a lot of the money goes, you can't deny or at all argue with the importance of prevention. And family medicine is the specialty that prides itself in prevention. Now, they get trained in everything else, but prevention is like to the point of, when you're in medical school, you're falling asleep listening to how much prevention. But once you start to actually digest the information and realize the importance, when you see the data, it's just like anything else. You learn it once, twice, 3 times, you sort of start to understand it, soak it up, and you're not able to teach it. By the time you're learning it to the point of being able to teach it and actually practice it as a physician, like, you start to realize the importance of the data. And there's a couple topics I'll just sort of try to touch on, like, a lot of people don't think about all the work that goes into making the recommendations for screening. There is just unbelievable amounts of science behind the recommendations that come out for any given population. Trying to determine if the screening is appropriate, cost effective, and has like an end point that makes sense to people in a system that won't burden itself financially. So so keep that in mind. That this topic, it's why I really care about it. I get pretty animated in the outpatient setting or even in the inpatient setting now when I'm trying to get people to just take care of themselves, because not only does it make more sense for their long-term health, but man, does it make sense for the system that's already kind of crumbling under its own weight, because our expectations of living non-healthy lives and then expecting medicine to fill the gap down the road is really costly. So, all right. So why screening? The point of screening, and this may be obvious, but catching diseases early when they're treatable. Screening, the purpose of screening is not to catch a disease too late. Is it? Yeah. So catching a disease too late in the disease state to do anything about it kind of fails our purpose of screening. So screening is not about just knowing; it's about knowing in a time that means something. More screening is not always better. That's a concept I think it's hard for people to wrap their head around. But over screening is definitely just as damaging as under screening, and we have to find out where that line is. And we'll talk more about that as we move on. Right test, right person, right time is kind of a way to frame this up. So what makes a good screening test? So as medicine moves forward and we end up with new diagnostics as time goes on, a lot of times there's this, people want to just jump in and use that diagnostic because they assume it's going to be a good outcome if we can find out about a problem. So it's interesting on the backside of that, finding out there's many times where the benefits don't outweigh the harms of screening. That's why there's so many major medical associations that contribute to what becomes the United States recommendation, which is made by a task force called the USPSTF, United States Health Screening Services Task Force. It's been around for a very long time. Right now, there's not a lot of support and funding for the science that's going into screening, so I think during the current political climate, we might see like a gap for a few years, hopefully it's not that long, where we just didn't have the support towards the science of screening of new things. As far as you get a new diagnostic and you have the money to go out and actually use it and test it on people and then look back afterwards and show that your screening actually did something. Some examples, ovarian cancer screening was one that's a well-established example where the harms outweighed the benefits pretty rapidly. It surprised everybody. So once we realized that we could find ovarian cancer with transvaginal ultrasound along with a blood test called the CA-125, which is a cancer antigen, a screening process was designed and put in place, and at the end of it, we didn't show that we were saving any lives. And there's a lot of nuances as to why that is the case, but there was an overwhelming amount of unnecessary surgeries and complications of those surgeries that ultimately didn't end in improving quality and quantity of life, which we'll talk about in a second, why those two factors matter when it comes to deciding if a screening test is appropriate and how they do it. PSA is another one that is just, there's so many ways you can slice that one. Right now, the recommendation is not to screen men over 70, or if they have a limited life expectancy less than 10 years. You can pretty much statistically prove there's no benefit of finding out if they have prostate cancer if they're in that group of men. Now, before that, there was the screening was digital rectal exam and a PSA, which is the blood test, on every man that comes in the door. And again, thousands of patients and studies showing that more harm was done than good. Now keep in mind, we're talking about two different things here. Like the risks of just screening and what happens after that because of the procedures and diagnostics and treatments outweighed, you know, what the patients who benefited. We're not even talking about the cost of it at this point yet. So there's other analysis that are just cost-based, like, hey, we can show there's a benefit and not a bunch of harm, but maybe the costs are too great for the population because what you're screening for isn't common enough to find often enough to make it worth the money. And so they have ways of measuring that. So we'll start right off with the big four cancer screenings. So colorectal cancer screening, colon cancer, there's different ways to screen for this. Like everybody knows what they are, but colonoscopy is the gold standard. It's recommended every 10 years in people with normal risk. It is a form of screening and treatment at the same time. It has the highest sensitivity, the highest specificity, and when we throw those terms around, what we mean is it's the most likely to find it if it's there, and the most likely to not misdiagnose it. You know, a positive screening test that actually didn't have disease, or a negative screening test that does have disease. Those are those two situations we don't want to see happen. You can kind of see why the recommendation for when to start colonoscopies came about. If you look at this graph, and it might shows up reasonable up there, but there's different lines here, and so, sure, sorry guys. Sorry about that. It was from UC Health, but I don't know what's going on. You've got different lines there. The term in situ means that it's so local. It's just in its own tissue. It hasn't invaded any tissue, and it's very easily dealt with. And then in situ cancer is usually dealt with at the time of colonoscopy, and so they're picking up the polyp and they're snipping it out. Versus localized, which is invading into the local tissues, versus regional versus distant. So as we move down on this right side over here, actually this is a pointer, isn't it? Is this a pointer? I don't know. Don't want to screw up my slides if... That's okay. Just on the side there, you can see as you move down, it's more dangerous as you go down on the descriptions in the box, but more dangerous as you go up on the lines in the chart. And they're all hitting pretty hard around the late 40s. So the previous recommendation of it, you know, starting screening at age 50 has been moved back to 45. There are other forms of screening. The FIT test used to be just checking for blood in the stool. Now it actually uses an enzyme test to be a little more accurate at checking blood early. But keep in mind, like, you'd be bleeding from a lesion in your colon by the time that was positive. And so not as ideal as having a polyp that wasn't causing any problems or bleeding. It was caught on a camera inside your colon. And then there's another one called Cologuard, which typically gets paid for and done about every 3 years. That one shows some pretty good sensitivity, specificity, but it's young enough where, like, the total outcomes of, are we actually helping people? So you can detect things, but does that mean people live longer after they've gone through whatever they have to go through to treat the disease? So breast cancer screening, actually I had one other thing about some colon cancer statistics. I keep forgetting it. I wrote down some things here just to let you know. There's colon cancer, lifetime risk of colon cancer in an average risk individual is about 1 in 25. The incidence rises sharply with age in the late 4th decade. More than 75% of colon cancers are diagnosed after symptoms develop rather than through screening. So we're not really doing a great job of getting people in. These symptomatic cancers present at significantly more advanced stages. The most common presenting symptoms are rectal bleeding, abdominal pain, altered bowel habits, and iron deficiency anemia. And that's almost always too late when those things kind of present at that, when you have those symptoms, and that's how you find out. It is a common conversation with patients. I feel fine. I'm not having any problems with my bowels. Well, by the time you do, if you do have colon cancer, it's probably too late. Only 24% of symptom-detected cancers, so these are people who are not screening, but rather finding out they have a problem because they have a symptom and they come to their provider. Only 24% are early stage, compared with 60% of those that were detected by screening. And approximately 60% of all colon cancer cases nationally are diagnosed at later stages, so more than half are diagnosed at a time that's going to be a pretty big impact, if not a death, from that cancer. Patients typically experience a median diagnostic delay of 4 to 6 months from the symptom onset of getting it worked up to the diagnosis, because there's so many other things that account for similar symptoms, if that makes sense. So it takes up to half a year to figure out you have colon cancer if you're going in because of one of these symptoms. Most people who present symptomatically basically have more advanced disease, and that's well known. So breast cancer screening. Women ages 40 to 74, choosing every 1 to 2 years is the current recommendation. Usually we talk about risk factors, including family history, and breast cancer is one of those where early detection clearly improves outcomes. So lifetime risk of breast cancer in an average risk woman, I use the term average risk a lot because if you have someone walk in the door with a really strong family history or a genetic form of breast cancer or colon cancer, then obviously the risk is different. But an average risk person, so we're talking 13% for breast cancer, so 1 in 8, which is significantly higher than the lifetime risk of colon cancer. The most common presenting symptom in an unscreened woman is a palpable breast lump, followed by nipple abnormalities and breast pain. Screening detected cancers are localized, so if we use mammogram to detect this, so you can't feel anything, haven't felt the lump, but in just mammogram or screening detected cancers, they're localized in about 90% of all cases. Localized meaning very treatable, probably not going to impact your longevity. Compared with only about 56% of those clinically detected, so you waited until you felt a lump. And distant metastases are present in 7.7% of clinically detected cancers. So this is a big one to remember. 7% in all the folks who are coming in with a lump or a distant metastasis for breast cancer is bad news, versus 0% for mammogram. So mammogram performs really well in that scenario. Women without prior screening have 43% later stage diagnoses 43% of the time, women without prior screening have later stage diagnoses compared to 25% in previously screened women, so who maybe not even following the screening protocol but were screened, and a 54% reduction in odds of advanced disease with screening. So, I mean, just across the board, cut the odds in half. And that stage shift depends on it translates to a substantial survival difference at the time of your diagnosis. Now there are a lot of good treatments nowadays, but the greater stage it's discovered, the survival goes down rapidly. So 5-year survival is 94% for screening detected cancers across the board versus 80% for clinically detected. And that didn't used to be the case, but like I said, there's a lot of good cancer treatment now that there wasn't available even a decade ago, but still. All right. Cervical cancer screening. So women aged 21 to 65, and there's different ways of determining. There's 2 different types of screening. Actually, I should say 3, but 2 that are very common. The pap smear, but also there's a blood test. The blood test is looking for an exposure or an antibody, and the 2 combined as a form of screening are quite powerful. When we look on this chart here, the VIA line, let's see, was this guy working? I'll try it here. I just pointed it on there probably. So the VIA line is just on inspection. So this would be like a long time ago, or even what we'd expect to find in like maybe underdeveloped countries that don't have these technologies available. The cytologic testing would be the pap smear. HPV testing is the blood test. And then control means nothing, no screening, nothing's being done. Just to link this for everybody, make sure everybody's on the same page. As far as we know, the only major cause of cervical cancer is HPV. So a virus, sexually transmitted, very common. Most folks that lived through the 70s and 80s, more than half of people a lot of times will be, in certain populations, will have HPV, men and women. So right now there is a vaccine against HPV, so this conversation may not even be happening in 20 years if we're successful enough in vaccination. It is a tough one for some reason. I don't know why. Because you want to vaccinate young adults, boys and girls, before they become sexually active. Regardless of how I approach that conversation, there's a lot of reluctance for parents, at least in this community, to vaccinate against HPV. But it'll be the end of cervical cancer if we can accomplish good vaccination rates. But as you can see here, with the different forms of testing, you can look at the incidence, and so that's a rate per 1,000 women. And cervical cancers are really a pretty big problem because usually by the time it's diagnosed, it's easy to spread. Let's see here. It's highly preventable with regular screening. Lifetime risk of cervical cancer without screening is approximately 2 to 5%. But effective screening reduces that to about 0.5%. It's unique that it primarily prevents cancer by detecting and treating precancerous lesions. Approximately half of cervical cancers in the U.S. occur in women who are never screened. So another group where most of the time when we find it, it's just because there wasn't appropriate screening. Early stage disease is asymptomatic. Symptoms like abnormal vaginal bleeding and discharge occur only when the cancer becomes more advanced. And there's obviously overlap of symptoms for things that are not cancer. The stage shift from screening is dramatic with cervical cancer screening. Regular screening is associated with a 95% reduction in stage 3 or worse, and an estimated 92% reduction in mortality, which is massive. Survival is highly stage dependent. 5-year survival is 91% for stage 1, and it drops all the way to 17% for stage 4. So single round of HPV screening in previously unscreened women reduced advanced cervical cancer incidence by 53% and mortality by 48%. So just a single screening cut those two things in half. That demonstrates a very profound impact of screening in unscreened populations, so a single screening. All right. So you guys can see, here's two other charts with the same measurements, but looking at discovering at a higher stage, which is the B chart, and you can see, let's see, basically what we're seeing here is like if we're catching it later despite the screening, you can see that the methods themselves become less important because we're catching it at a later time. So again, getting screening done at the appropriate earlier age than later. Lung cancer screening is kind of an interesting newer topic because in the past there was no guideline, and a lot of providers kind of winged it and just got chest x-rays, which is really inappropriate when you look at whether or not a chest x-ray can detect lung cancer in any appropriate way or early enough. So now we have a low dose chest CT, so computed tomography, so we're talking like is a CT scanner, taking multiple x-rays. The technology's improved to the point that we can get some very decent imaging with very low radiation. And that was not the case. CTs are pretty high radiation, say 10, 20 years ago. They still are, but this particular method of screening, it uses an existing CT scanner, but it programs it in a way that it's able to see enough detail with a very little amount of radiation. And so as that technology improved, then it became a question of cost. It is kind of a costly procedure, and the cost of it has gone down. And over time, we've reached this point at which the USPSTF has determined that cost effectiveness is worth it now. And now we've been making the recommendation for certain groups of people who are at the highest risk to get lung cancer screening with a low dose chest CT. So adults ages 50 to 80 with a 20-pack year smoking history. What does that mean? You smoked a pack of cigarettes a day for 20 years. You smoked a half a pack a day of cigarettes for 40 years. You smoked 2 packs a day for 10 years. You can get the idea, but that's how that comes about, that cumulative smoking risk. And then you can see current smokers are quit within the last 15 years. So if you have a 30-pack year history, but you quit 20 years ago, you don't qualify because by now you would have experienced cancer related to your smoking, and your risk is approaching that of a non-smoker, so you got lucky. How often do we get these? They do recommend them annually. I do find it hard to convince patients to go get them annually. I think because it's just a new form of screening, maybe people are not as comfortable with it. Let's see. And why it matters, lung cancer is the leading cause of cancer death. Hopefully someday that's not the case. But so on this particular topic, I wanted to bring up something that I am somewhat passionate about, and it's really interesting. Some interesting facts. Low dose CTs for lung cancer screening reduce lung cancer mortality by 16 to 25% in high-risk individuals. That's not a very big number. Adults, let's see, there's different methods of reading and performing these lung CTs, but the number needed to screen is pretty important to listen to this one. To prevent one lung cancer death is somewhere between 130 to 323 people. That's a lot, right? I mean, as a doctor, I've been kind of watching this low-dose chest CT because there are a lot of people who want to be screened for lung cancer, but there's never been a good way, right? And they want reassurance that they quit smoking and they're living a healthier life, but they want to make sure they don't get lung cancer. And you need to have screened those individuals over and there's different studies, so somewhere between 6.5 to 10 years annually, right? It's a lot of screening, right? And here's another statistic. That results in 3 lung cancer deaths prevented per 1,000 people screened.
Wow.
That's not very good.
No, I wouldn't think, this is one of those tests where even with false positives, which are not that common, and false negatives, the damage to the patients who don't actually have cancer is on the low side, believe it or not. Most of the time, the way these protocols are set up, you have to have further screening before you'll go in and get a biopsy or something, okay? And that's where the risk starts to go up. But they're pretty good at figuring out like when to biopsy. So this one's always surprised me because I always wondered how did they argue that this was worthwhile, right? And so to give you an idea of the science that goes behind how do we prove if it's worthwhile or not, they use different metrics, but one is called the quality adjusted life year, okay? And this combines both the quality and the quantity of life a person may have by detecting the cancer and having it treated and saying, all right, so a perfect healthy human life for 1 year is 1 quality adjusted life year. And no one's gonna have that. Okay, you end up having lung cancer and surgery or whatever. If you live a year after that, we'll take that number 1, and then we're going to times it by the quality of life, which will be less than 1, right? It'll be like 0.7 or something. Let's just quantify it. So they actually attempt to quantify people's quality of life following detection, treatment, and cure, let's say, okay? So a quality, Q-A-L-Y, a quality just life year, equals 1 year of life lived in perfect health. So a year lived with significant illness or disability counts as less than 1 full quality. So then the next question is, if you're a policymaker and you're saying, well, so you guys you want all the insurance companies to say, okay, we're going to get these annual CT scans at a major discount for the patient. We need to know the cost per quality, or the cost per life year gained. Okay. Well, and again, it sounds laughable, but this is where it goes, right? And so then some people, well, you can't put a price on life. It's like, well, that's not what we're trying to do here. We're trying to like manage a population. It's not about the price on a life. We're trying to prove whether or not this screening is appropriate, because man, this could get expensive quick. And we've got this pool of people paying into this. Some of them aren't even smokers. And so our model of care in the U.S. is really interesting, right? So we sort of, as a group, we were forced into accepting the model we're in, for better or for worse. And the cost of healthcare, I mean, this is an example of, people talking about the cost of healthcare and trying to determine, at least in the U.S., what are we willing to pay for. So the cost per quality, or cost per life year gain, measures how much money must be spent on a screening program or a treatment to gain 1 additional year of healthy life. For example, $81,000 per quality means society spends $81,000 for each extra year of good quality life the intervention provides. Everybody with me on that so far?
Yeah.
Okay. In the U.S., interventions costing less than $100,000 per quality are generally considered cost-effective and worth funding. Similar to what society already pays for dialysis, cancer treatments, and other accepted medical care. For comparison, low-dose chest CT lung cancer screening comes in at around $49,000 to $81,000 per quality and falls well within this acceptable range and is comparable to mammography and colonoscopy screening. So the key insight is that these metrics help policymakers decide which health interventions provide good value and not whether a life is worth a certain amount, but whether limited healthcare dollars are being spent efficiently to maximize health across the population. So truly, what we're saying is, if a person, I order a low-dose chest CT on the person, and we diagnose them with lung cancer, they get treated and it's a cure. Not the cost of their treatment or anything that comes after that are we talking about. We're talking about just the whole screening mechanism itself. All the low-dose chest CTs we did on all the different people, the visits to get to the point of deciding to screen, and that person now lives another 10 years after their diagnosis and treatment of lung cancer, and the lung cancer didn't even affect their quality of life in any way whatsoever because it was caught early enough, then we just cashed in on 10 qualities at $45,000 a year so is this making some sense? And so when you go to that much effort to prevent a disease, you kind of want to talk people out of smoking really bad. You know what I'm saying? Like, as a physician, like, you're just really motivated to prevent all that in the first place. And then you realize what a difference it makes, public health programs, to not let a kid start smoking in high school, right? And the amount of effort alone, not just that, and the money, the cost of all these, of arranging and figuring out whether these screenings should be done or not, is just, it's amazing the amount of time human beings spend in this arena trying to screen preventable diseases that are usually a result of making some bad health choices. Not always. Just putting that out there. There's a lot of stuff we screen for that just happens anyways, but this one in particular has always interested me because I would always read the statistics on the low-dose chest CT and go, oh, how is that worth it? But when you stack it up with the quality, it actually stacks up right alongside mammograms and colonoscopies. And I think we have to wrap our heads around that concept is we're screening and finding something so early. Imagine the cost burden of not finding it. Because is that person going to say, I've got stage 2 lung cancer, I'm not going to get treatment because it's going to cost everyone else too much? No, they're going to go full treatment, and now we're talking about something that's hundreds of thousands of dollars, and maybe get, think of the quality after that, when you've had radiation and maybe even surgery, and maybe you don't have a very good 5-year survival rate, you live another 4 years, and your health kind of sucks during those 4 years. And so you think about those things, it's more expensive both monetarily, but also morbidity, like morbidity being the suffering a human goes through. And so when you think about prevention, I mean, I still, to this day, I'm glad I became a family doc. I feel like that's, if we could somehow unlock the ability to convince people to live healthy, I don't know how to do that, but I try every day, right? So,
I have a question about that.
Sure.
Air pollution, is that figured into any figures for lung cancer?
Well, I would say air pollution is probably not the big one, and that's kind of a separate topic.
Okay.
But just risk factors of lung cancer. I mean, we always focus on smoking because the lung cancers we see are typically smoking related, like small cell lung cancer. But there's other cancers in non-smokers that are really interesting, and I'd say one that should pique our interest here is radon. Radon's a big one, and so have any living space that's at or below ground level should be tested for radon, and it might scare you. I mean, this area has a lot of radon, and radon can definitely, like, you spend your life in a home with high radon levels, your risk of cancer is pretty high. And that's one of those that you're not going to get screened. You're not going to meet the screening. If you're a non-smoker, we're not going to screen you for low-dose chest CT. But if we screen everybody for lung cancer who didn't smoke, all of a sudden that quality is off the charts, probably $500,000+ or more. I would guess it'd be a lot. So, but yeah, good question. I think it's these studies too have to focus on a very small group of people to make it worth proving. And you find a cancer, like, well, first of all, why do we care what's the leading cause of cancer or death, right? So it's like, it's a big one, but yeah. So it gets a lot of attention.
The health department used to do free radon tests. They used to have free ones.
They don't anymore. I'm not sure. Nowadays, honestly, it's crazy, but you can go buy a continuous radon monitor. It's not that unaffordable. I don't have one, but I've heard, like my neighbor's got one. But pretty interesting. So I grouped the next ones kind of into. So we've talked about the 4 main cancer screenings. The other group we're going to talk about are heart and bone health. Blood pressure screening typically start at age 18. Every 3 to 5 years until you're getting to middle age. But once you're over 40, we try to get at least screening done annually. You'd be surprised how many people make it to their 40s and don't know if they have high blood pressure or not. Like, they literally just, and it's not like it's an expensive thing or that you can't stop at the pharmacy at Walmart, or it's just odd. A lot of times, when we get to we give this group of people who come in and they're young, like early 40s, because they had to have a procedure done, and they went there and they're like, oh my gosh, your blood pressure is 170 over, and you need to go see a doctor, and that's their first time in the doctor's office. So, high blood pressure has many implications in the body, and it's just such an easily treatable problem. So, let me see if I wrote anything. Undetected hypertension approximately doubles the risk of heart attack and stroke for every 20 millimeters of mercury increase in systolic blood pressure, with untreated hypertensive patients having 77% higher cardiovascular death risk and 153 higher stroke death risk compared with those with normal blood pressure. In young adults, even stage 1 hypertension, so that would be under 140 systolic, so like 130s over 80s, like 135 over 85 would qualify for stage 1, carries a 1.75-fold increased risk of cardiovascular disease, and 65% of these individuals progress to more severe hypertension within 15 years. Lifetime risk of developing hypertension is 80 to 90% for middle-aged individuals. And again, I don't know if that statistic is just U.S., because U.S. statistics are quite skewed compared to the rest of the world. We'll talk about that with diabetes too. Lifetime risk of developing hypertension being 80 to 90%. Once blood pressure rises, there may be irreversible vascular damage, even if the treatment was eventually started at some point. So you want to kind of catch it when it starts to hit stage 1. Blood pressure screening is remarkably simple and inexpensive compared to other screenings, such as the cancer screenings we talked about. Yet achieving guideline recommended blood pressure goals could prevent what they would estimate at 3 million cardiovascular events in 10 years in the U.S. So if we could just reach everybody, I'm just checking their blood pressure and getting them treated, 3 million cardiovascular events. So that's pretty wild. A 10 millimeter reduction in systolic blood pressure is associated with approximately 50 to 60% lower stroke death risk and 40 to 50% lower coronary death risk, making hypertension one of the most modifiable and I would say affordable cardiovascular risk factors. So, like if you're going to your provider, I would say nowadays when you go see your provider, there is so much expected of that person. You know, they will always look at your blood pressure. Occasionally they're gonna forget to talk to you about it, or there's just too much going on. So I'd say, you know, when you go to your own visit, be your own advocate. Understand if your blood pressure is over 130, over 80, you should probably be watching it and talking to someone about it. And if it doesn't get mentioned during your visit, bring it up. I have to do little tiny studies to keep certified as a doctor, and that, you know, you have to do stuff within your own practice. And one of the simple ones I did was, how many times does someone come into our clinic and leave with a high blood pressure and they didn't even talk about it? And it blew my mind. So I actually did this thing where the medical assistants had to give the patient a piece of paper if their blood pressure was elevated to remind them to talk to them about it. Because you get in there and it's just like, it's just chaos for 30 minutes for some people because they have so many other medical problems going on. So that's something I would recommend everybody do and keep in mind. Let's see. So this chart here is cumulative incidence of cardiovascular events. And when we say cardiovascular events, we're also talking about strokes. So you can see, so this is in percent, and this is over a 20-year time period. So from someone basically getting diagnosed or not, but if you have untreated stage 2, which is going to be greater than 140, 15% at 20 years. And we're talking mainly heart attacks and strokes. And that doesn't necessarily mean it be a life-threatening one, but you definitely impair your life afterwards. So medicine's pretty good at taking care of heart attacks, which is really crazy. A lot of people end up with heart attacks and have very little effects afterwards if they've been treated. It's pretty lucky to be in that kind of, but strokes are a different story. Strokes almost always cause a problem afterwards. It takes a long time to get over. Cholesterol screening. So cholesterol is another extremely preventable it's something we can lower someone's risk impressively over the course of a decade, even more over 2 decades if someone's willing to stay on treatment. When we're talking about cholesterol, what we're really focusing in on is the LDL. LDL is what is going to be the more atherogenic particle, and we're always constantly calculating that LDL with other risks. Do you have high blood pressure or diabetes or something else in addition to that LDL? Are you a smoker and you have a high LDL, or you just have LDL on its own? And the reason that matters is there's a lot of good data, and you can always ask your provider, you know, given my statistics, what difference is getting on a statin going to make for me if my LDL is this number, if I bring it to this number? what will be the risk I'm averting? What's the protection I'm afforded by that? But you got to keep in mind, this is when we're talking about cholesterol. Lowering that cholesterol is something that lowers your risk over a large period of time. It doesn't lower your risk by tomorrow. So if you can lower your cholesterol overnight, then it's not going to really change your risk at all. But in 5 years, your risk is going to be going down. In 10 years, maintaining a lower LDL, and then as you get beyond that, people can actually have a reversal of plaques in their arteries if their LDL stays low enough. So convincing people that statins are not poison is tough. I don't know why, but there are quite a few people who end up with side effects. I think that's it. Like up to I would say 1 out of 30 people a lot of times will have a pretty notable side effect on a statin, and so that gets out. And people always know someone who took a statin who had a side effect, but the rate of a life-threatening or any organ-damaging side effect is extremely low. And so it's one of those where it doesn't hurt to try, and it's one of the most commonly prescribed and tolerated medicines there are, and a very easy way to reduce people's risk. All right, so diabetes. So diabetes screening has changed a little bit. In the past, it was a fasting blood glucose, and it had to meet certain criteria. Now insurance is covering the hemoglobin A1C, which is a very simple blood test that is very accurate. And so in a single blood test can tell you if you have diabetes or not, or if you have pre-diabetes or just on a spectrum. So these charts here are really impressive though. So in US adults, you can see and this is pretty hard to read, sorry guys. I'm trying to cram a lot on one slide. So this is basically showing, like, the blue line is undiagnosed diabetes over time, and up here we've got the orange line is diagnosed diabetes. So you can kind of see, like, this undiagnosed has not really changed much, probably because we've been way better at screening over time, and that I think the diabetes we see ends up becoming diagnosed pretty rapidly. People, when they start to develop diabetes under the pressures of the American diet and lack of exercise, it happens quickly. It's not like so a lot of people end up having some other problem related to diabetes that gets them diagnosed. But you can just see the rate climbing over time. And you can see diabetes undiagnosed going down over time. I put this chart below, which is interesting. So prevalence of diabetes in the United States just continues to go up and has increased quite a bit. Japan has had a decreased amount of diabetes. France and Spain decreased. Switzerland, no significant change, but also the lowest rates in Europe. There's clearly a difference between us and other countries, and I think our probably what we value as far as, like, what we consider our quality of food and what we do. I'm amazed how much diabetes is in our community. Like, I usually in a clinic day would, out of all my patients, 5 or 6 of them would have diabetes almost every day. And just the conversations I've spent talking with people about how to eat, and it's not necessarily that people don't understand how to eat. I think the other thing is we don't value quality food, not as a person, as individuals, but as a country. And so I think we've really through advertising and through what's expensive and available, we show that we value inexpensive, low quality, carbohydrate-laden foods. I mean, it's just kind of that's how we roll in the United States. And in a place, and you go to a place like Huerfano County, and I have patients that are diabetic, limited budget, and they truly struggle finding quality food that isn't, like, that's within their budget, that isn't going to cause problems with their diabetes. And so, people say food desert, and maybe that's too strong of a word, but to me it's not. Like, for some people you say we live in a food desert, like, oh, we don't live in a food desert. There's a Safeway and a Second Choice, and you're like, it's like, well, yeah, but you go there, and it's like, to get, like, if a person were to go there and buy some really quality meat, like chicken and fish and other things, like fish, like, what's that? It's very expensive. Not, for most people that live in Walsenburg. And then, you go to a place like a bigger store where maybe it is cheaper. You go to like Pueblo or Springs, you go to like Walmart or something. But the amount of similar calories you can get in a carbohydrate that's not healthy, or in the advertising, like, it's like you're knocked over by it. Like, it's not like there's all this healthy food falling off the aisle in your face, So we've allowed the stream of food and how it gets to us, and how, like, what are we doing with the things we grow in our fields? Well, we're turning a lot of these things into really simple carbs, into cereals, into things that are not all that healthy. And so as a country, I don't know that we are warming up to how big the diabetes epidemic is, how the obesity epidemic is, and now, unfortunately, I mean, not that I'm against the GLP drugs, but that's going to be our solution. A really expensive injectable drug to make us not feel like eating. Which how long is it going to take before, Conagra and all these other big companies start beating up on the GLP, like the pharmaceutical. You guys are making people not want to eat my potato chips, But, so yeah, I think, you see, U.S. diabetes prevalence increased nearly 50% in the last 2 decades. So in 20 years, we're 50% more diabetics, rising from 9.8% in the 2000 era to 14.3, 2017 to 2018. Countries like Japan, Denmark, Sweden, and France maintain stable or even declining rates at just 2 to 5%. Pretty wild.
How about kids? Are you seeing it more and more in
Yes,
young people?
yes, and obesity in kids, but not, down here, I can't say that I personally, we just don't have a large pediatric population down here. But when I was in residency, I think at that, or I did training at Children's. Children's has an outpatient practice that's like, gosh, I can't remember, it's like 8 stories high. And now, there'd be an area where the endocrine saw kids, and it's hard to quantify as a provider. I just know my overwhelming impression was the adults that I treated in this community. I couldn't believe it. Diabetes prevalence here is very high, and more than it was in residency, and even working here for my first month in the clinic, I'm just like, man, I feel like I'm an endocrine clinic. Like, all I do is diabetes. And it was tough back then when I first started here, because a lot of the meds we use now, commonplace, that are covered, were not covered. And I had a ton of people on insulin that really didn't need to be on insulin, and it was tough because insurance companies were constantly changing which one was covered that year, and there were just so many other better treatments. Now it's not too bad because there's a lot of other treatments out there that are more affordable. They didn't used to be. They've come off patent. But still, it was amazing. It was an amazing burden of care, just all aimed at diabetes. And I was medical director there for like 8 or 9 years, and could never keep a diabetic educator on staff. We now have a care manager there that does diabetic education, which is awesome and helps outreach. But yeah, I don't know. I don't have the answer either. Like, I think the answer is we need to start being more civic minded, more country minded. Like, as a doctor, like, I'm taught to treat the disease and try to prevent it and whatever. But I just feel like when you see these statistics by country, like, this should be more of a political solution, right? And but the other interesting question would be, okay, so what about our own community though? Like if we really, everyone in this room just say like cared a lot about the health of our neighbor, and we were trying to improve the health of our community, what would we do? Well, a lot of communities focus on the food chain for their community, and they try to work on getting, you know, like better streams of food coming in. We have our little farmers market, and it's really cool. But like, what if that was like 100 times more, you know, impressive and inexpensive and whatever? Like as a community, we really valued that, and you almost could not afford to not go to the farmer's market and buy vegetables that were healthy, and you know what I mean? That would make an impact.
I think it's education too. People don't know that they give half off. For people that don't have money.
They do at the farmer's
Yeah,
market?
you can get half off if you make under $29,000 a year in a family.
No, that would make it, yeah, I think
Super.
that's nice to know. I could definitely get that word
Tell
out.
people that, yeah.
But yeah, you know, you look at some communities that they really try to turn that around, and that's how they do it. They look at their food chain. They're not as much. It's not throwing a bunch of medicines at it.
Right.
And this is a common thing. You know, we think about like we talk about this is the stark difference between Americans who will talk about, well, our DALY limit's $100,000. You know, so we do all this screening and we find this disease that was preventable and we treat it and we can give you. Well, we're willing to do that as long as we get it a year for $100,000 or less. And meanwhile, some people don't have clean water to drink. It's like, so, it's pretty wild. But you know, again, I think coming back to prevention and education is a huge one. But yeah, it would. If you were to make a social change, though, to turn this around, it would be like make healthy food cheaper, cheaper than unhealthy food. But you'd actually have to. It would be costly to go out and live off of some of the things that cause diabetes. But that would be a hard thing to pull off. So. Bone density, we're getting near the end, guys. Bone density scanning, a lot of people, we talk about it and they don't know, I throw around the term DEXA scan, that's just like a fancy x-ray. Bone density is something that probably needs a little more attention for most people as they get older, only because if you actually do have a hip fracture, that's one of the big ones. We're also talking about vertebral compression fractures or any fragility fracture, but the hip fracture is a big one. You look at the statistics for hip fracture, people don't do well after they break their hip, even if they get it repaired, okay? So we're looking at all women age 65 and older, anyone that's under 65 postmenopausal with risk factors. Those risk factors are mentioned below there. And then for men, there's really not good evidence for routine screening, but a lot of men can have risk factors, like if a man has low testosterone for a lot of years at a young age, there's certain things that might want us, make us want to do a DEXA scan. DEXA scans are really cheap. They're easy to do. There's hardly any impact to your day. You go in, get your DEXA, go home. But I mentioned this one thing. This is kind of counterintuitive because there's insufficient evidence for routine screening for men. But down below I said prevents debilitating fractures. 1 in 3 men who break a hip will die within a year. That's a statistic to like, oh wow, Again, men are not the group we focus our screening on, but just to give you an idea, that's the most impressive statistic of broken hips, but there's still more to come. Nearly 1 in 4 patients die, so this is men and women combined, within a year. So a hip fracture runs somewhere as high as a 30% mortality rate within a year. Only half of it depends on your community you live in, your resources, like your support after you break your hip. So when we say these things range, it's not like you got to look at the statistics. When you hear these statistics, you should apply them to Huerfano County and say they're in the worst case scenario, or worse than what I'm telling you right now. Only half of survivors regain their ability to perform basic daily activities like bathing and dressing. Only 1 in 4 survivors recover their ability to perform instrumental activities like shopping, cooking, and managing finances. The morbidity burden is comparable to stroke in terms of disability-adjusted life years lost. So disability-adjusted life years is like the opposite of the other adjusted life year thing we were talking about. Men obviously have higher mortality rates than women after hip fracture. But overall, super easy, super low risk, super cheap screening test. Now, I guess here's where we connect. Great, we find out we have osteopenia or osteoporosis and we're high risk. Can we just fix that before I get a hip fracture? The answer is no. So it takes a long time to turn that boat around, but it does. Like, you can make an impact with the medicines available that's sizable, and that's it would be amazing if we could just say, hey, I'm gonna give this medicine, and in a year you're not gonna have any hip fracture risk, and you're gonna have normal bone strength. And that's not the truth. People get on these medicines for years, and they slowly start to either build bone or maintain what they had. But I would also say when we identify a person who's at really high risk, they have severe osteoporosis, they've got all the risk factors for a fracture, we do prevent the fractures. We get them into physical therapy. We have someone go and check out their home and make sure they're not doing anything that's going to lead to a fall that would lead to a fracture. And we drive that home at every visit of, listen, you can't fall. Like this, you're you know, it's just like throwing a wine glass. Don't do it. You know, it's like, but I think once people have that in their minds and they get motivated to get stronger, the strength isn't necessarily just to build the bone, it's also to prevent them from falling. It's to improve their gait, their ability to catch themselves when they trip. And so there's a lot of things that we do that reduce the fracture risk other than reducing their osteoporosis. Does that make sense?
Yeah.
Okay. All right, so just real quick by group, I don't think we have any 39 or youngers except for in the back.
Yep.
There we go, all right. So blood pressure, weight, depression, and I threw some in here that I didn't talk about today. Depression screening, STI, sexually active, we say STI screening, but I would also throw in there, that kind of links into cervical cancer screening, and then beyond that, getting vaccinated to prevent cervical cancer, HIV screening, and cholesterol and diabetes if you're overweight or have anything metabolic going on, or you have a family history of high cholesterol. So 40 to 64, cholesterol, diabetes, breast cancer, colon cancer, lung cancer. And there are definitely people out there that at the age of 40 have already accumulated a 20-pack year history. And then after age 65, you can see we just keep adding on to the group of previous screenings, but we get to start stopping on certain things. Cervical cancer screening, even if you never were vaccinated and you had pretty regular cervical cancer screens, so pap smears throughout your lifetime, by the time you hit 65, the likelihood that you would develop cervical cancer from that point on, for many reasons, is extremely low, so we stopped that. Breast cancer screening, that one's kind of up to debate still, but most of the time we're stopping in mid-70s. Depends on the person's health and their family history. A lot of times, if you can imagine your health is good enough to live another 10 years, then the breast cancer screening should be left on the table to discuss with your provider, and why. You know, if someone's, you know, just extremely healthy in their late 70s and they want a mammogram, I think it's very reasonable. But as you get older, even if you are healthy, the likelihood of being able to change your path if we diagnose the breast cancer by getting treatment, because of all the things that come on with that treatment and how a person's body reacts to that treatment when they're older, the window starts to close on it being a treatment that's efficacious, right? They're just going to help you. So, tests you don't need. All the ones we do, you know. So we usually do a lot of extra testing at health fair screenings. Lifeline screenings drive me crazy. It's monetizing the screening. You know, it's a bummer that it's like someone going out and taking advantage of people. They do a little bit of some of the screening they do is probably borderline okay, but most of the time not. And it's usually low quality and usually is not directed appropriately, so it's wrong person, wrong test, wrong time when you get the Lifeline screenings. they're not super expensive. I feel like they're in the hundreds of dollars range depending on what you end up doing. But routine EKGs, so that's when they check your heart out by putting, looking at electrical tracing. Those have really shown to screen and find things that are important outside of symptoms. Chest X-rays, that used to be a really common practice, annual chest X-rays in smokers. Testicular cancer screening. Testicular cancer, we still recommend self-exams frequently, so you start to notice if there's a problem, but to do like the old turn and cough when you're, when you're like in PE or something, like it should be something. I feel like when I was in high school, we'd have to go get our physical and we get a testicular exam, like there's no proof that I ever did anything but traumatize young boys, right? Truly. And then the ovarian cancer I mentioned. Now, there's always caveats. If someone's got a high family or a large family history, high risk of something more genetic, genetics will change all this probably in a decade or two. Where we get genetic testing that will actually probably help determine our screening tests. Right now, there are geneticists where if there is something that's kind of interesting in a family, it's like, boy, that's interesting. So-and-so had this cancer, and who else had what? And you're like, ooh, that doesn't seem, like your mind just tells you, that just doesn't seem right. That just seems a little too much cancer. And literally, I can just refer someone to a geneticist now, and they'll go to talk to that person, maybe even on their computer at first, do an interview, and then the geneticist can do some statistics and say, yeah, we should probably test you for these 3 genetic anomalies, and if positive, we're going to test your whole family and let them know what their risk is. A good example would be kind of a separate topic, but a connective tissue disorder. I have a friend I grew up with in high school. We still talk. His kids are similar age to mine. His daughter broke her arm at home, and they were getting investigated for child abuse. And I'm just like, oh my God, like, no way that the parents would do anything to these kids. And we spend a fair amount of time with them. But long story short, I never thought about this, but my buddy Dave has a what we call a Marfanoid appearance. He has really long arms, he's lanky, he's really hyper flexible. He has a connective tissue disease. His dad, you have things about his dad died at a fairly young age with a heart valve disorder. And so they ended up getting genetic testing and come to find out him and his daughter both have a connective tissue disease that at this point they're going to get MRIs annually for because it's that big of a deal. Their risk of having an aortic aneurysm or a heart valve problem, and so and all that came from her having a really high fracture risk as a kid. But that kind of progression of, hey, now what? Tell me that again, and let me get you this geneticist. That didn't exist 15 years ago, and now it's pretty commonplace. So, vitamin D screen. I might disagree a little bit with this one. This was I was looking up guidelines. It's like some of these tests are not that expensive. The harm of having a low vitamin D and correcting it, I feel like as we get older, vitamin D tends to have a lot of important effects on our health. So people with low vitamin D have a higher fall risk. So to the point that we supplement people in long-term care settings. I think part of the thing is we're talking about the cost to society for screening. If everybody's bearing the burden versus I'm just interested in my own personal health, what do I do? That's a really shady area to live in because nowadays there's just a bunch of things out there that aren't worth your money to waste on it, but not worth worrying about either. And I think that's where it's important to talk to your provider and trust them. There's so much misinformation. Being a patient these days is difficult even if you're a doctor. I put that out there. There's so much misinformation, and I know enough where I'd be like, oh, really? And look into something, and you're like, oh, gosh, not again. And I go down rabbit holes as a doctor because I'll be like, oh, wow, that's. I was thinking that might be the way things turned out, and you look up something like, oh, that's BS. Someone, it's just another Instagram feed or something. But as a patient with no medical knowledge, I can imagine if certain things are intriguing as a doctor, they must be really intriguing as a patient, you know? So I don't know. Let's see, all the stuff we do in your annuals, like the big CBC and the CMP, and there's not a lot of, see thousands upon thousands of results before something abnormal pops up, and sometimes that abnormality doesn't make a difference, right? So it's reassuring. But yeah.
Are you going to continue doing the annual blood draw with the, is that still going to
As
happen?
far as I know, and that's actually kind of a function of the lab. So the lab director gets to determine if they have the bandwidth to do that. But as far as I know, they keep. There was a period of time we had a lab director for a couple of years who didn't really. It wasn't like a priority for her, so it didn't get done. But because it really does, all that burden rests on the lab folks, and they have to put in a fair amount of time of their own time to make it happen too. So. So yeah, that's it. I think.
That's great.
I do have to get to my meeting here pretty quick, but if you guys have any burning questions, I'd love to answer them. This topic can be really dry for patients, but that's why I said that thing at the beginning of it being, it was dry for me through medical school, even some parts in residency, but in practice, when you start to see those statistics thrown around of like, geez, like we do a cutoff of $100,000 per year of life as like, hey, that testing's worth it. Like, to me, that's still pretty expensive. Not that we're putting a price on life, but to say as a cost to the, to society. But caveat is, what if you don't catch the disease, which you're not going? So you didn't screen. Now it's even more expensive to that group of people who's all paying into the same insurance, right? Because treating that disease late is way more expensive than treating it early. And so you got to keep that in mind too. And we don't live in a system where it's like, no man, you smoked and you got to pay for your cancer treatment yourself. I mean, that's not how we operate as human beings. That's not what I'm advocating for either. I think our system, I think we're just very lucky to live in the system that we do. It's just kind of sad how expensive it is, because we really need to focus more on our own health as opposed to how do we fix problems that are preventable. We should value feeling healthy, being healthy, eating healthy, and that's the hard part, because meanwhile there are just so many countries out there that are doing it right, number one, or just don't have the resources to do it right. And I feel like we have the resources to do it right. So,
Go ahead. I just have a real quick thing.
Mm-hmm.
It's about vaccination.
Yep.
You've been
Oh, and
trying
I know that was on the list today, and I actually got through all this. Like, I'm gonna just stick with screening.
Anyway, but just real quick thing. You've been trying to get us to do the shingle shot for a long time. So why does now it doesn't affect us because we don't have prescription coverage anyway. But why does Medicare not pay for shingle shots after 80?
Their effectiveness goes down.
Okay.
Well, all vaccines' effectiveness gets incredibly less effective at age 65 and onward, just because of our immune system as a functional immune system. So that's why we try to, that's like that turning point of opportunity of like, hey, let's get you vaccinated for these things so you can build up immunity that you can carry through a period of time. This can be, that have the biggest bang for your buck, right? But shingles is a tough one. Like that one's phased in, over the last probably 3 to 4 years, where we've seen way better coverage than it used to be. But also there's a history of shingles vaccination. So the old shingles vaccine was not that effective. It was, I mean, you could prove its effectiveness, but compared to the new Shingrix, like night and day. Like I still, to this day, have not run into a patient who got a Shingrix vaccine who came into an office visit with shingles. And I always ask, not to be a butthead, but like, oh, you should have vaccinated. No, that's not it. I'm just interested. It's like, I seriously never, the two statistics on the vaccines I think are interesting. Like for me, that's my personal experience. Is like I haven't met someone yet who at least had shingles bad enough to come see me who got the Shingrix vaccine. But the other one is, I don't think there's a case of tetanus in the United States after a single vaccine, to my knowledge. I think that's still a statistic that's flying around that like we get it every 10 years, but it is hands down an extremely effective vaccine, right? And it's old. It's still the same old tetanus vaccine, but yeah, no, I would guess that they're weighing out like paying for it, because the insurance company, unfortunately, they're not like, okay, number one, make patient happy, or healthy, right? They're like, no, make my investors happy. And so like they're sitting there going, well, what's the effectiveness here? Like, what does it cost if a patient gets shingles? It's not life-threatening, right? Lots of morbidity associated with shingles. So a third of people who get shingles as an adult will have lifelong pain, even after it's gone. A third of people are going to have some form of neurologic deficit, usually discomfort, but not to the point of it being like terribly painful. And a third of people are going to get over it and have a scar, right? So they're looking at those statistics, and at the age of 80, my guess is the vaccine effectiveness is starting to fall off. And to them, it's like a toss-up. But like it's very costly to them. Like a person gets in that 1/3 group and they weren't vaccinated and they had really bad shingles, they're coming. That's like 10 office visits to them probably. At a cost of hundreds of thousands of dollars to the insurance company, because the patient's coming in, I'm in pain. What can you do for my pain? We treat it, they come back, that didn't really work, and sometimes for some people it's like there is no answer other than, maybe we look at like ablating the nerve and trade numbness for pain. So shingles can be really bad, but I think they're honing in on the group of people that paying for that vaccine is going to get them the most bang for their buck too, meaning provide enough protection to prevent it. But I saw them come across like an 85-year-old who got vaccinated at 83 and got shingles, and so I don't know, that'd be my guess though.
It's expensive too.
It is, and that's another thing, is like someday that will be the case and it'll get covered real easy, and but the cost to a person, even if you just consider their time and the energy that goes into experiencing that illness, so the morbidity side, highly worth it. The cost is minimal compared to what will happen to you if you get it. So
Thank you.
yeah, for sure. Did you have a question? Okay.
Thank you so much.
Absolutely, guys. If you guys would, at some point, two things. One, like if there is a topic, I don't care what it is, if it's medical, submit it to the library, because this one was kind of just like, I feel strongly about prevention, but I'm a family doc, and easy for me to come up with a presentation on. But like if there's a topic you guys feel strongly about and want me to present, I'd be more than happy to research anything. Just tell the library and we'll put it on the.
I wish more people had one.
Doesn't matter.
They can see it
We'll
on
spread the
film.
word. We'll spread the word.
They can see it on the film.
That's true.
Yes, and the other thing is you guys need to go to BOTS. Okay, everybody has to go to BOTS.
Yeah, I'm going
Tomorrow.
tomorrow night, right?
Tomorrow night and Saturday.